Hello and welcome to this session on world challenges to telehealth, where we bring you today a very exciting panel of experts literally from around the world. We have our colleague Rafael Franco from the National Telehealth Center in Portugal, Dr. Michele Griffith from the US, a board member in the International Society for Telemedicine and eHealth, but also medical director at Premise Health and founder of 21st MD, Alan Taylor with lots of different hats as well, also part of the committee of the Australian Telehealth Society, and Professor Ganapathy with a very long list of achievements. He's the past president of the Telemedicine Society of India, and director of the Apollo Telehealth Services and Apollo Telemedicine Networking Foundation, among others. We are going to look at some of the challenges around telehealth around the world and in different places in the world. But I would actually like to start out with asking our panelists to introduce themselves a little bit further, but then also actually look at some of the successes that they have achieved, some of the things that they have been and are currently doing in telemedicine and telehealth in terms of service provision and how that works. And then a bit later on in the session, we'll definitely also look at some of the challenges that still exists around organizational aspects, financial reimbursement aspects, regulatory aspects, and so on. I would like to hand over the floor to Dr. Michele Griffith to let us hear a little bit about your experiences in the US, and I know you even have experience and knowledge of other places as well, in terms of what you're doing exactly, how that works, and what you have seen as benefits for organizations, for patients and users, and for healthcare professionals when it comes to telehealth services.
Thank you so much. I first would like to say thank you for allowing me to be a part of this important discussion and panel. I've been certified in internal medicine and integrative medicine, been practicing for close to 30 years, and have been fully integrated into digital health and telemedicine for over a decade. I've been a corporate medical director for 13 years now. And of course, as we all have had, I'm sure, experienced challenges with the adoption of telehealth. Prior to the pandemic, in the United States, we had up to 3% utilization of telehealth. And certainly we all looked to that day when there'd be some inflection point, tipping point, and certainly the pandemic, we passed that with the pandemic, but it did allow us to see how significant the integration of digital health and telemedicine has been to improving outcomes and quality of care. Prior to the pandemic, we actually had at our practice of about over 4,000 employees, we had already been utilizing telehealth in a clinical blended model for 2 years prior to the pandemic. So with our familiarity and training of the patients, we had about 94% of our patients already utilizing the app and utilizing digital health. So when the pandemic hit, it was actually a smooth transition for us. I had trained our staff, our ancillary staff, and certainly the patients. So that, along with the distribution of blood pressure cuffs and home kits, home A1C kits to our diabetic patients, we were actually able to roll right into seeing our patients on a regular basis. We had our staff actually printing out and keeping track of with data which patients had not been seen and needed to be seen. So we use the robust nature of our EMR to help us to keep track, and we had some really great success stories. So it worked quite well for us and really allowed us to see how impactful and how important telemedicine happens to be, particularly when we are dealing with pandemics. And if we look over the last decade, how we're seeing, epidemics actually occurring more frequently. So it's not really a temporal issue, it is a long-term issue, and we need to work towards how we can fully integrate this, not only for corporate patient population, but also underserved. I also served as a interim chief medical officer for a federally qualified health center as well during this time. And we worked diligently with grants and donations to assist with getting blood pressure cuffs to patients, with also pulse oximeters, and also we're able to identify an EMR that was low cost that we could see patients on their phones. So I think we always have to keep in mind that there's this huge gap in terms of healthcare disparities, and we have to always be mindful of how we're making sure that those that are underserved and uninsured are not left behind in this digital revolution.
Thank you very much, Michele, for this view on I think, how you have been able to more easily expand some of the things you were already doing, but now in the past year, out of necessity, you had to, but were able to intensify and expand those services. And you already touched, I think, on some of the challenges in terms of reaching the ones who need it most, and also being able to finance that in one way or another. So we'll definitely get back to that. Now let's move over to India, to Professor Ganapathy, whom as part of the Apollo group has a long time and very extensive experience with telemedicine, telehealth programs. So please, Professor Ganapathy, give us a short, brief overview of some of the main things that you have been doing, and that maybe over the past year has, all, just like in the case as Michele Griffith was explaining, has expanded or maybe even exploded because of the need for more distance consultations and medical services.
Thank you, Frederic. As you know, every sixth human on the planet Earth lives in India, and therefore telemedicine in India is almost equal to telemedicine in the world. Now, it all started in 2000. I am a neurosurgeon, basically. I was the president of the Neurological Society of India. I was interested in technology right from the very beginning, and I specialized in stereotactic radiosurgery, which we introduced for the first time in South Asia. In 2000, I got bitten by the IT bug, as you call it, and then persuaded the chairman of the Apollo hospitals to let me start a telemedicine unit. Of course, 21 years ago, the world was totally different. The first 10 years I spent probably in just evangelizing, talking, creating an awareness, making doctors as important as patients, understand the benefits of telehealth, trying to make distance meaningless. My favorite phrase was making geography history. But again, for a country of India's magnitude, the growth was very, very little. It was very depressing at times. About 7 years ago, for the first time, we started a public-private partnership project with the government of Himachal Pradesh in the Himalayas. So providing telemedicine at a height of 15,000 feet, with 5 months in a year, the temperature was minus 25 degrees centigrade, snowstorms and landslides. This was a tremendous challenge for us. We took it up, and I'm very happy that today we run the highest altitude in the world to the best of my knowledge. We also have a 24/7 tele-emergency services. More than 30,000 consultations have been given in this small area, including about 1,800 emergencies. So once the state government was very happy, other governments started following suit. And today we run 6 major public-private partnerships with 6 state governments in the country. We have completed 13 million teleconsultations under this banner, and today we have reached almost 10,000 to 11,000 teleconsultations every single day. About 10% of our work is by franchisee centers. The Apollo Hospitals has its own, under its brand name. We have about 350 to 400 centers in suburban India. We have not yet gone into village, but we have certainly penetrated into tier 2, tier 3 cities. India is unique in several ways. We have more than 1 billion people with phones, mobile phones, 40% of which are smartphones. Coming back to the last 18 months, I think is very critical. On March 24th, 2020, India declared a national lockdown. Exactly 24 hours later, the government of India notified for the first time telemedicine practice guidelines. So this very clearly told us what we can do, what we cannot do, and so on. Of course, there are several gray areas, but prior to last year, there was absolutely no legality about it. As can be expected, this gave a tremendous fillip. And in the last 10 months, the growth of telehealth, I personally like the word telehealth rather than telemedicine. Medicine implies a doctor-patient diagnostic one-to-one relationship, whereas I believe very strongly that information and communication technology could be used to promote wellness, promote health, and that I believe is the future rather than diagnosing and treating diseases. So coming back to this, I don't want to take too much of time. A single strand of RNA has acted, according to me, as a global chief transformation officer. I have always been telling for the last 10 years that telehealth, particularly in a developing country, in an emerging economy, will never really take off. We will not achieve the critical mass essential to go into orbit, as ISRO says, unless there is political will. And the last 1 year, it has been absolutely fascinating from a telehealth evangelist point of view to see no less a person than the Prime Minister of India mention telemedicine in every time he addresses the nation. Today, every chief minister, every chief secretary, every bureaucrat, the topmost bureaucrats of the country only talk about telemedicine, telemedicine. Farmers have got together and started telemedicine units, corporations, municipalities. At least 20% of the million people now under home quarantine are probably have access to or can connect through a telephone, including a WhatsApp video, to thousands and thousands of volunteers who are giving their time free of cost in order to handhold those who are in quarantine. So I really think COVID has dramatically changed everything. And maybe in the next round of discussion, if we have some time, I can elaborate on this. Thank you, Frederic.
Thank you very much. I think indeed the point you're making about evangelizing is very important. And yes, the one good thing about the past year is indeed that telehealth has come very high on everyone's agendas, and it certainly has helped to put it more in the spotlight. And I think when we'll get to some of the challenges, it will now be about sustaining sort of that momentum that we have seen. Let's hear a little bit now from Alan Taylor, who is in Australia, but also has experiences in Brazil. So it will be interesting to hear from you what, let's say, the situation is in Australia with telehealth implementation. We heard a little bit from India about regulation that has now also been put in place. So Alan, give us a view on your experiences in Australia and beyond.
Certainly. Thanks for having me speak to you today. I've been involved in telehealth initiatives about more than 20 years now. And more recently, I've been researching how telehealth services have evolved in both Australia and Brazil, and there will be a book published about this. And the interesting point is that countries like Australia and Brazil are very similar, and they go about things in a very similar way because they have very largely decentralized populations, and they have inequalities in healthcare. But to the point, telehealth in Australia is not a new thing. For most of last century, telehealth services have been provided to rural and remote Australians by the Royal Flying Doctor Service. Just to give you a bit of a understanding about Australian healthcare, Australia has both a public and a private healthcare sector. Public sector largely deals with acute care. The private sector, in the form of general practitioners, deals with primary care. And funding comes from both state and federal governments. What happened with the advent of the pandemic was that telehealth services were extended through funding for consultations to everyone in Australia, not just those people in rural and remote areas. And so towards the end of last year, we saw that about a quarter of the 10 million general practice consultations that occur each month, a quarter, were done remotely by telehealth using video or telephone. Specialists also contributed about 15%, and mental health practitioners had an even higher involvement in telehealth services. Also, nurse practitioners and allied health workers were able to conduct telehealth consultations. Those figures have declined slightly this year because we don't have a severe pandemic within Australia at the moment. And it's also interesting to note that people have adapted more quickly and more readily to using the telephone for paid consultations. So it's about 2.5 million consultations overall every month that are done by telephone, and only about 200,000 of those are done using video systems. It's also interesting to note that doctors based in rural and remote areas have made much higher use of telehealth, especially video consultations. But I would put that down to their previous experience of providing healthcare to their cohort of patients who are disadvantaged in many ways and have to travel many hundreds of kilometers sometimes to see a specialist or other practitioner.
Okay, thank you, Alan, for those insights. And again, yeah, as you said, telehealth has been around for a long time, but you've seen expansion and more use and I guess more awareness among all the stakeholders involved, both on the patient and user side, the citizen side, and as well as on the healthcare professionals and healthcare provider organization side. So I think that remains a very important topic. And then now it's a matter of even building further on that and putting in place some of the necessary requirements, frameworks, regulatory, financial frameworks, and so on, also professional licensing, etc. So I'm sure some of these issues may come up in our second round of interventions. But let's go to our hosts, Portugal now. We have Rafael Franco from the National Telehealth Center in Portugal. Rafael, we would like to hear from you, knowing that indeed telehealth has also been around already for quite some time in Portugal. How that came about, and then what happened specifically also in the past year with all of that.
Okay. Thank you, Frederic. It's really a great pleasure to have you all here in this Portuguese digital event about health and eHealth. Thank you for all. I'm a nurse. I begin with I'm a nurse. I started working in a Portuguese hospital, an NHS Portuguese hospital. But I always look to technological new ways of doing some things and new organizational forms of work, and start to interest in telehealth and digital health. Let me focus on our NHS, because our NHS covers all the country, delivers care, primary care, hospital care, also in a huge part of so 55 hospitals and so on. So we covered almost all the population in Portugal. And as you know, Europe doesn't, each country manage their health not in a common way, but in a particular way, like the social affairs and so on. So Europe also have to look, and this pandemic helps to look as health as a value of a continental value, not only a country value. I suppose that is the future way. But in our NHS in Portugal, we start, as many others, like with the telephone line. So the triage line has a huge importance since '98 in Portugal. It starts in that time. So it's a phone line that knows that complementary to the 112 and helps the people to manage the acute health. So acute problems that they have. So the triage line delivers the best place to the people in the time. And manage the problem that they have in the particular time. So that phone line is now better than ever. It's a huge help in manage COVID-19 in Portugal. So which people have symptoms or not, they call to the triage line, and we have also the same process in digital because in 2030. Portugal has invested huge in have electronic health record national in NHS, but also with the information of the private sector, like prescription, and our electronic health also helps to manage in the digital way. But when the times come with the COVID, the phone is the technology that we have more in hand, and the phone is what the people most use, and our contact center, NHS 24 is the name of this concept that also will turn to more digital, not only phone line, but is a huge part in the acute management of the disease. But we also put in the place a teleconsultation platform that allows all the doctors or nurses in NHS to use in a secure way, identifies the patient, identifies the doctor, and they can deal with the app or the website for the electronic health record, and they use that also. Is very important, not only to the acute way, but probably the telephone is more important, but for the managed health or the secondary consultations in the hospitals, this is a huge tool to manage that. Nowadays, we are working now also in a NHS for a telemonitoring platform that is normalize this help that the doctors can have, the doctor, the nurse can have to the patient that are in home. It's a more comfortable way of give some data to our doctor or nurse, and we are now working on that. But as you said, we are now seeing that telehealth and digital health are in the same hand close to achieve more that simple care that we are used to. So we now are in the place that to look of new organization models. The people are in with that feel that we need to do more to achieve the awareness of what we are going to see in the future, not only for pandemic way, but also the chronic disease and the elderly people that we're going to have. Also Mediterranean country that many people that are getting old and new people that doesn't came. So migration is a huge and important path, but we have to deal with that health issues in our country too.
Okay. Well, I think it's also interesting that you also mentioned the let's say the ordinary telephone conversation, Alan was also referring to that, is let's say one of the primary ways of reaching patients or patients reaching the helpline. It doesn't indeed necessarily always have to be video consultations and so on. Of course, important, what you also mentioned is the electronic health record in the background, let's say as a backbone to the entire system where patient information is accessible and where updates can be provided and so on. So, and clearly that is indeed in place. And we have now heard from all four of you about the ongoing telehealth services that have existed for quite some time, that intensified even over the last year, and then the next step, as I mentioned already before, is how to maintain this, how to properly regulate all this, how to include it into payment or reimbursement frameworks and so on. So I'll hand over to Michele once again to look at some of those challenges that you see for yourself, for the organization that you work for, or maybe that you have seen in other places, and what needs to happen to address those challenges, or maybe things that are already being addressed and where others could take your lead or use some of your advice on those things. And I also, well, we'll come back to all of the panelists, but I certainly also invite you to jump in or to question each other, or maybe bring in some of the things and how they are happening in your country, in your organization. But Michele, over to you.
Sure, certainly. So certainly in the United States, I would say probably the number one challenge that will be a focus, of course, is reimbursement. So it's quite complex with respect to private payers, government payers, and certainly prior to the pandemic, there were so many variables from state to state. In terms of reimbursement, parity laws, up to 38 states had parity laws, others did not, and they were different in every state. With the pandemic, of course, we're still in a state of a public health emergency. So many of those restrictions were relaxed, which made it a lot easier for practices to adopt telemedicine, knowing that you were going to, or telehealth, knowing that you were going to be reimbursed. So we see that this current reimbursement structure will remain in effect at least through the end of 2021. But after that, that's the big question, right? We certainly would hope that this would remain in effect, but the likelihood is that there's so many complex questions with respect to reimbursement that more to come on that one. Additionally, I would say our licensing, we do not have national licensing here. Doctors are required to have a license for every state where the patient is located. So certainly during the pandemic, that too was relaxed. We had emergency licensing. I had, 14 licenses granted to me, which have all been rescinded, but the 3 that I had before the pandemic already, so that too is an ongoing challenge. Thirdly, I would say we saw a rapid increase in the adoption of telemedicine during this pandemic to see patients. However, now that things have improved and doctors' practices are now opened and patients are being seen in person, it worked well when you had no other option, but now we have seen a decline, although it's still higher than pre-pandemic levels. We've certainly seen a decline in telehealth visits. And so I think we do have to address training and quality of visits. You want to ensure that patients are having a great experience. And certainly now that they have been exposed to telehealth, health visits. I do know that it's a lot easier. Many patients say, well, do I have to come in? You know, actually, this is quite convenient. I can see you in my pajamas, or I don't have to get a babysitter to come see you, or I don't have to spend money to come see you. So certainly there's been an increase in adoption because of that, but certainly we have seen the decline with in-person visits. And I think training of physicians in terms of quality visits is very important, and also patients. Lastly, I would say we did, if you compare adoption rates in urban versus rural areas, again, those underserved areas, those remote areas, the adoption rate was not as high because of issues with bandwidth and access to technology. So that too is always a primary focus in terms of how we can ensure that those patients, potential patients in rural communities have access and have the necessary bandwidth so that when we are dealing with pandemics or just in general, we can improve access to care. So.
Okay, thank you very much. And yeah, I must say that certainly in terms of training, quality assurance, and etc., these are certainly things that within the global network of the International Society for Telemedicine and eHealth, we're looking at more and more, and also working with a number of members and partners to see if and how we can support providers and users around the world with specific training programs, with quality programs, quality assurance programs, and so on. So that is important, but I think all the other topics that you touched upon are equally important. Professor Ganapathy, from your side and in India, does that resonate? Is the situation similar, or still do you see other challenges or in the way in which they are being addressed in India? You'll have to unmute yourself.
Instead of confining myself to challenges with your concurrence, I would like to talk more about a wish list. If I were the head of telemedicine for the Indian subcontinent, there are 3 things which I believe are not given enough emphasis today, which I would like to concentrate on. One is what I would like to call the business of telehealth. I have attended hundreds of telehealth programs in the last many years. All the programs either deal with ICT, the challenges in technology, with EMR, peripheral medical devices, and clinical, of course, clinical telemedicine, teleradiology, teleophthalmology, etc. But not many of them talk about how to self-sustain, how to keep. It's very easy to start a telemedicine project, but it's extremely difficult to ensure that it is viable and continues to be there. One of them is revenue generation. One of the methods of somebody has to pick up the bill. There is no such thing as a free lunch. So one of the advantages in India, a major decision which the Indian government has taken is to authorize and make it legal for insurance companies to reimburse teleconsultations. However, this is going to take quite some time before it is actually implemented at the ground level, but I think this is going to make a major difference. Another area in telehealth which I find very seldom discussed, not globally, even more so outside India, is what I call patient empowerment. I think there should be emphasis on promoting health literacy. I would guess at least 50% of clinical presentations, be it physical or be it a remote consultation, could have been avoided entirely if only the family had known to check their blood pressure once in a way, to check their blood sugar, and so on and so forth. We need to use ICT to promote health literacy for patient empowerment, knowledge empowerment. This is to be given equal importance. The third and final point I would like to stress on is we are a long way from exciting the beneficiary. I mean, I have personally given about 3,500 neurosurgical teleconsultations, but how many of them? So I try my best to excite the beneficiary. So I think the person at the other end, instead of spending his time concentrating on technology or on filling up 150 forms and filling up that and this, he should try to empathize with the patient, sympathize with the patient, the body language of the doctor. See, selling healthcare, if I can use the word selling, is not like selling a pizza or buying a ticket for an airplane or for a train ticket. You need to communicate. You need to show the beneficiary that you are his only reason for your existence. I belong to the BC era. I'm not talking of before Corona, I'm talking of before computers. I was the last neurosurgeon in the country who was trained before computers even came into the healthcare system 45 years ago. So I like to, with all the technology at my resources, obviously I'm a technology buff, but I would spend time listening to the patient at the other end. All he wants is somebody to listen to him. Make the entire process of teleconsultation. Forget the technology. Technology is a means to achieve an end and not an end by itself. Make the patient feel, wow, that was a fantastic 10 minutes I had. Look at how Amazon packages its products. Look at how all the e-commerce companies do it. 80-year-old people in rural India get excited by the way in which these products are packaged. I think there should be a total emphasis on creating a consumer delight, on making the beneficiary get that wow factor. That is not going to happen only with 5G and with 200 Mbps bandwidth. That is going to happen when the doctor empathizes with the patient. The patient feels, look, that guy spent 15 minutes listening to me. I want to go back to this doctor. This is what is happening. And in a small study which was conducted a few months ago in India, a company carried out a study of 6,000 patients and asked these patients, once the pandemic is denotified, would you still continue teleconsultation? And the answer was very surprising even for me. They said, we will go back to our doctor who has been treating us for the last 10 years, provided he uses teleconsultation. In other words, the average doctor in India, at least, is not at all fascinated by online, all my degrees and all the papers I've published and all my affiliations to search for me online. He does not want Professor Ganapathy with 500 papers. No, he wants a Professor Ganapathy who will listen to him, and nothing like the family doctor. So I think you should encourage existing doctors to adopt technology rather than go about and trying to introduce technology to people who have forgotten about doctor-patient relationship. I may sound very old-fashioned, and certainly this is not acceptable by the younger community of today, but unfortunately I belong to the 20th century.
Well, I think you certainly have, if there are any people in our audience, healthcare professionals who are not yet or not doing much telehealth or providing telehealth services, that you have been able with some of those wise words to convince them. And I keep in mind let's say the people focus. That should be the main focus really, and then of course your three guiding principles are also very good to keep in mind and to strive for. Alan, back to you. Some of the remaining challenges that you see in Australia, in other places, and how to address them, or what is being done about them.
Well, we have some of the similar challenges that have been mentioned so far. We don't have challenges with regulations or the legal framework. Telehealth services are totally legal. They're regulated through the payment system. So if doctors don't do telehealth if they don't get paid for it. That's what it boils down to. Licensing is done on a national basis. All Australian doctors are registered nationally, so we don't have that problem. But nevertheless, we have found that there's a need to improve the competence of many doctors in the quality of care they can give using telehealth. There are still doubts about that. And some of that boils down to training and education, which can definitely improve. Courses and accreditation in telehealth and eHealth and so on are around in Australia, but they need to become more widespread, and more doctors and other professionals need to actually do those courses. One of the problems is the medical curriculum is very, very full. So that is an issue in itself. In terms of coming back to quality, Australia has been leading the development of international telehealth guidelines through the International Standards Organization. And a brand new publication will hit the streets in a few days on that. So watch that space. That could be useful at a national level, particularly for larger organizations, although because it's a risk-based set of guidelines, you can apply it to any sort of organization or any sort of service, any sort of doctor. What we have found, though, is that the increase in use in telehealth services can be put mainly down to forced acceptance. So doctors are not necessarily voluntarily accepting that they have to do telehealth. They just know that there's no other alternative in many cases. And how that will play out in future, we don't really know. Many doctors still find it very strange to talk to a patient on the telephone, believe it or not, let alone do a video consultation. Also, some doctors find it difficult to incorporate telehealth consultations into their normal place-based workflows. So it's disruptive to their business in some ways. Telehealth, well, Professor Ganapathy mentioned that technology is not the problem. I have to agree with him. What we've found is that really the continued operation and development of telehealth services you can never guarantee that they're going to continue. It's really contingent on what happens over time at the social level. So how is practice legitimized? What are the things that tell a doctor that what they're doing is a good thing? How do doctors build confidence, particularly, and patients build confidence in telehealth services? And what are the relationships that are built both between doctors and administration staff, doctors and importantly, doctors and patients? There's been a tightening of the recent regulations to really mandate payments only for telehealth consultations to patients that have been seen by their doctor within the last 12 months. Now, there are upsides and downsides to that, depending on the speciality. And then also there's the question of resources. We all need resources to do the job, whether it's technology or skills or funding.
Okay, well, thank you for those insights. And again, yeah, I hear you're putting a lot of stress indeed on competencies, on training. This has come up and certainly is an issue, or is important to look at, and how it can or should be integrated into curricula for medicine students, nursing students, and other professions, but also in ongoing continuing training for people who are already in the workforce. And then you also touched upon, yeah, organizational structures. How do you embed it into current practice, and then how can it be, let's say, a meaningful and useful addition, and not just something, you know, on top of all the rest? It really needs to integrate with or become part of the overall way that healthcare services are delivered, or the way that people access healthcare services and consultations and so on. I think these are indeed very, very important. Rafael, I guess to end with you, yes, what are some of the, or what is the main challenge that you see in Portugal that needs to be addressed?
In this time, I think the challenge is more or less quite the same. So we have also a regulation that look to this activity. The political will is greater to to help the sustainability of our NHS. But in terms of adoption, we see the same that Michele said, that the telephone is high, but the patient, the citizen, when it needs is when it's the only way that to achieve some advice or some counsel, the telephone works. But after that, we have to put to allow that the relationship that Professor Ganapathy said, that allow that relation, the video is very important. So it's not the same that we are doing this video conference only by phone. We see each other, we see our faces, we see our reactions, and this helps this contact, and this is nowadays our adoption problem is not only the people empowerment, so the people know what is the ways that use that technology to achieve the doctor, but also the professionals empowerment to upskill this capacity to deliver the services in this way. So which times is better for the patient, that, like Michele said, don't have to ask for a babysitter, or don't have to stop her important day of job to go to a physician and to have that they need in that time. So the adoption, I think, is the experiences, to focus on the experience of the patient, to see the doctor, to when it, or in telemonitoring, when there is something, it's easier. The pairing of the device or something is a way too simple to the patient to deliver the information that the doctor or the care team needs. It's quite the experience is now our focus, is now our challenge. Also in the reimbursement side, we have to look for that. In Portugal, the reimbursement, we have a reimbursement for teleconsultation, for telemonitoring in only three pathologies, but we now see that it's more important to look at the path, all the path, the digital path, and also all the path of the patient, and see when it is useful to have at the distance services or not. And now we are working on this field for not only regulation, the reimbursement, but to the process that all that the professionals feels secure, feels that is the right way to do that.
Okay, well, thank you very much. And then unfortunately with this, we already come to the end of this session. I know there's so much more to say, and especially share some of those wonderful experiences that you all have. I think that's the good news for everyone. There is indeed a lot of experience around the world with good implementation and use of telehealth, with good examples of how to assure quality, of how to provide training, and so on and so on. And then certainly also within our global network of the International Society for Telemedicine and eHealth, we see a lot of that. So we invite all of our viewers and listeners to certainly have a look at the ISFTEH as a network to join, to participate in, to share your own experiences, but also to learn from others. So with this, I would like to thank our four panelists and also our hosts of the ehealthsummit.pt. And we look forward to keeping in touch with all of you. Thank you very much.
Thank you very much.
Well, bye-bye.